My name is Carla Sumala, and I am with the SF Tech Council. I'm here with my colleague, Andrew Broderick, and together we are co-directors and sort of the public face of the Tech Council, but we are just a tiny part of a larger group made up of 25 member organizations and partners and collaborators all over the city of San Francisco and beyond. And we're so happy you could join us this afternoon. We've got a really good hour and 10 minutes or so ahead of us with presentations, time for questions and discussion, and we're eager to get started.
Thanks, Carla, and good afternoon, everyone. As you just heard, Carla and myself are the public face for the Tech Council. We are a multi-sector collaborative, so working across sectors here in San Francisco to address digital inclusion for older adults and adults with disability, who together make up about 25% of the city's population, so quite a large representation from both populations within San Francisco. For those of you who are new to the Tech Council, we really try to kind of work like a community table around which all these leaders from different organizations and sectors come together to talk about digital inclusion issues, and strategies for which we can ensure more equity in terms of outcomes when it comes to digital programming and other activities that can close the digital divide. And, for a number of years, trying to work out, what's the best way for us to kind of engage with the healthcare system and looking at the digital equity needs that exist within that kind of organizational setting. And now today, the kind of digital divide is recognized as a super social determinant of health. And so therefore is increasingly kind of recognized as something that needs to be addressed rather than just recognized. And we've invited three fantastic speakers here today to really kind of bring their insights, bring their experience, and share what they're kind of seeing and learning through their work around kind of health, technology, and equity within the healthcare system. And we're going to kind of have three of those speakers really talk first about the kind of equity and technology issue. And then we're going to have a fourth speaker who's going to talk about food as medicine. So our first speaker today is going to be Adimika Arthur, who is the founding executive director for HealthTech for Medicaid, which is a nonprofit. And that brings all of the stakeholders, payers, providers, patients, policymakers all together to look at, innovation and ways that the kind of Medicaid system can be kind of changed for the better. After that, we'll have Amy Sheon, who is president and CEO of Public Health Innovators. And Amy is one of the kind of experts nationwide really looking at digital inclusion programming within the health system, and especially the role of the digital navigators. And then finally, we'll have Jamie Robbins, who's a program manager at Community Health Plan of Washington, which is a managed care organization. And they've actually implemented a digital navigator program across 25, I believe, or 21 FQHCs, federally qualified health centers. And she's going to tell us about the design and implementation and what they're learning through that in Washington State.
Good afternoon or good evening. My name is Adimika Arthur. I run a nonprofit called HealthTech for Medicaid that was just mentioned. And just by way of background, I'm an epidemiologist by training and was a hospital administrator for about 15 years before starting HealthTech for Medicaid. Being 16 miles, my house is 16 miles from Silicon Valley, and really understanding that we were creating products and services to go into delivery systems that may not have been equitably or inclusively designed. That was really the impetus to who's really thinking about, at that time, 72 million people on Medicaid, what is now 91.4 million individuals on Medicaid. So HealthTech for Medicaid really is a nonprofit. We're a convening body. Our goal is to bring everyone, payers, providers, policymakers, entrepreneurs, investors, advocates. But the most important thing is that we actually center all of our work on the individuals that are on Medicaid and their caregivers. And there's a lot of reasons why individuals on Medicaid and their caregivers, the data actually shows that individuals who care for someone on Medicaid often die before the person that they're caring for. Since we know that most of Medicaid, 50% of Medicaid is children, that becomes equally significant as you're talking about quality and duration of life. And clearly where we sit in the ecosystem is really around myth busting. We consider ourselves to be a mission-based market enabler. We really want cross-sectoral collaborative partnerships across the ecosystem. Medicaid's done 56 different ways in this country. We have worked really hard over the course of the last 4 years and some change to do infrastructure and ecosystem development. When we first started, there was really not any standards or competencies for entrepreneurs entering into the Medicaid space, no playbooks or ways in which to even think about the government as an adequate customer base. And then we obviously do a lot of issue and policy advocacy. So Medicaid's 57 years old. And so we usually have strategies that guide the work that we do. And so we have 5 to 7 strategies as a great play on 57 years of Medicaid as a program itself. So obviously we try to dismantle the Medicaid constructs and radically help impact health equity. And I think as we're talking about equity today, one of the things that our organization does, it kind of sits at the intersection of where health equity and tech equity come together. So when we think about literacy, and you're thinking about some of the most underlooked populations, you tend to think about financial literacy, right? But we don't often, because many people are poor, right? Or genetically unlucky, or on fixed incomes, or living check to check, being disabled. But we don't often think about tech literacy, digital literacy, health literacy as a part of that literacy conversation. And that's a big part of what our organization strives for. Advancing equity as thought leadership. This is a new field to some, but for people like me, I've been a practitioner doing health equity work for over 25 years. I've grounded my entire career in making sure that we think about how we can live lives to the best of our attainment and ability. And that is not equality, that is equity. There is a big difference there. Because Medicaid is a federal program, the federal is the floor, the ceiling is the state. It's a state and federal partnership. We really try to do intentional policy work that really thinks about the lives of individuals that we serve. We want to see diversification of research advancement in Medicaid, and that is on the academic side, as well as in any other pieces of where, whether that be in consulting or in pharma or in any other part of the ecosystem. We support and drive actually making sure we have the right voices that come out, right? Representing 91.4 million people is a very hard feat without having them be a part of your solution set. And so that's why I say all of our work is really centered on those individuals who are actually on Medicaid, their storytelling, their life experiences, their lived experiences. And then really driving inclusive and equitable design. And I'll spend a little bit more time talking about that because we really are pushing for equitable and inclusive design of products, services, delivery systems, capital markets, and narrative change. So when I think of telehealth specifically, and I'm talking a lot to the ecosystem here at the San Francisco Tech Council, one of the things we want to think about is the intersection of where disaggregation, the language we use, our perceptions, the voices we hear, and the narrative we collect come together as it pertains to addressing systematic barriers and, whether that be racism or any other societal structure. Increasing access to care, and also thinking about affordability. A great way of thinking about that is often when we talk about like determinants of health, we talk about social determinants of health. Well, there's really a lot of other determinants of health, right? Political, economic, environmental, ecological. And so how can we make sure that we're being encompassing of not needling over just the social determinants of health? Those of us like myself, I grew up in public health. And so I knew deeply over 25 years ago, right, when I got my MPH, that social determinants of health have been around for a long time. But if you were to do a lit search back then and a lit search today, you would have sent like an incredible volume increase, probably 200, 300, 400, 500 times the amount. So we've really indexed on these words, but oftentimes the words don't really match our actions as to what we are interested in and how it really does impact people's quality of life. The one thing I do want to make sure we talk about as it pertains to the Tech Council is really There is a tethering of untanglement of current Medicaid, and I've used this buzzword a few times, but I think it's really important for everyone to understand and know, which is determination. Who by like show of emojis or getting off mute or whatever has heard about redetermination happening? Obviously, we were all impacted heavily by a pandemic, but what that did do was a few things. It gave us protections under a public health emergency, right? And so under that public health emergency, one of the things that happened was the federal government prevented states from kicking people off of Medicaid. Medicaid at the start of the pandemic was probably in the range of about 80 million individuals. It's now grown to 91.4 million. So this slide is a little dated, even though it was just from a couple weeks ago. And so it grew almost 20 million from the beginning of the pandemic. And so I try to ask people to think about, who are these folks? So hands, does anyone know anybody who either moved physically out of their county or moved out of their state during the pandemic? As of December, the only way to actually communicate with Medicaid members was by mail. That's insanity. So one of the things that's going to happen with Medicaid is everyone on Medicaid will have to be redetermined. That will take an 18-month process, but it starts in 17 days. Starts April 1st. So every state, the public health emergency was decoupled December 23rd of 2022. So not very long ago, but they're estimating anywhere from 18 million to 23 or 24 million people may not re-qualify for Medicaid. And so what does that mean for individuals' lives? People who have moved in-state and across state lines, because oftentimes your information may not be accurate in the system. People who don't have adequate or accurate data in the system, in the government system, people with limited English proficiency, individuals with who rely on caregivers or neighbors or others to help them actually do their commuting digitally, individuals with disabilities. There's a lot of people with traditional mistrust of the government. And there's also individuals who have poor loyalty relationships, either with their providers, their caregivers, or their MCOs. Those are the folks who are at risk. The biggest thing is like, how are we going to do that? That's like the big elephant in the room, is like, how are we going to reach all these people and make sure that they have access? And then I can send some slides afterwards to really talk to you about what does this mean, the expiration of the public health emergency, literally as of April 1st. And what does this mean in access and the operations of your own institutions? But bigger, like, what does it mean for health equity? What does it mean for quality care? I would say there's a tremendous, I mean, you've got over 400,000 individuals just in the city of San Francisco at risk, right? A third of Californians. We do work nationally, but I would say, you know, I've lived in California for over 21 years and spent lots of time in the 1115 waiver and many other things on Medi-Cal specifically, but it does speak to quite a bit that's going on across the nation and what this means for our community-based organizations, our hospitals when people don't have coverage, right? People's actual lives and their ability to go in and in still being in a pandemic as well.
All right. Well, thanks so much. I'm just thrilled to have the opportunity to talk with you and be with my co-presenters, two of whom I know. And I do want to just say that I'm a full-time consultant. I have been for the last 2 and some years. And so I will be mentioning some of my clients, but I want you to know that they're my clients because I believe in what they do, and that's why I'm sharing their work with you. But I'm into radical transparency. So if I'm mentioning somebody who I have or had a financial relationship with, you'll see it like in a red box like that. Okay. So I think that health systems have a profound opportunity to influence digital inclusion and equity in society in general, but the digital inclusion community and the health communities just have not come together. So I'm going to go through some of the ways that the health sector can really influence digital inclusion. So first, they're a huge customer of health technology, and they could be really demanding that technology makers are including accessibility features that are effective for seniors, people with disabilities, people with access issues. So that's one thing that we can do. And there's a wonderful toolkit that came out a few months ago that is for the inclusive development of health technology. So it's full of resources, and I recommend it to you. Another thing that health systems have the ability to do is show on a massive scale the proportion of people who are using digital technology like patient portals, as was happening in the mid-2010s. This paper from my colleagues in Cleveland showing tremendous disparities in patient portal use for 240,000 people. And not surprisingly to those of us who were aware of these disparities, the disparities in video telehealth during the pandemic are exactly parallel to portal use disparities back then. So, but again, healthcare has this profound opportunity to tell us about the digital use. Now, that study in Cleveland was among the first to show that the influence of broadband access on using technology, and in fact, living in neighborhoods that had most people on internet was the biggest predictor of whether or not people themselves use the portal, even after controlling for differences in those neighborhoods. That's a very important consideration. Now, it's also important to recognize that the most common kinds of digital health, like patient portals, telehealth, and the like, they're having a direct impact on health by helping people find quality health information, manage their illnesses, et cetera. But we have to recognize that healthcare only explains about 20% of modifiable disparities in health outcomes. And so all that stuff, telehealth and the like, is at a population level not going to have a huge impact. And the reason for that is, of course, because of the social determinants of health are what has the biggest impact. However, insofar as the healthcare system can help people get connected, not just for telehealth, but for addressing their social needs, that's where healthcare has the hugest opportunity. They may only want to get people connected to use telehealth, but they should want to get people connected for the same reasons that they now want to help people with their housing and their food insecurity and all those other things. Now, the third big thing that health systems can do is understand and address the root causes of digital disparities, which internet is one of the key ones. Now, in my community in Cleveland, the three major health systems are all involved in this, some of them putting antenna or satellites on their roofs and beaming wireless signal into underserved neighborhoods. But this finding from the patient portal disparities prompted our digital inclusion advocates to wonder, well, what's going on with the internet in Cleveland? And they found that AT&T did not upgrade in the poorest areas from dial-up. And that's where the term digital redlining, I imagine you've heard of that, was coined. But AT&T really isn't the boogeyman here. It's historic redlining, because you can see that the current digital redlining pattern really exactly mimics historical redlining. But this is where we have to dig deeper if we're going to try, if healthcare is going to try to get involved with digital inclusion. Because when you look at poverty, you can see that the map is the same. The proportion of people who don't have internet, life expectancy differences of 24 years exactly replicate the historic redlining. Percentages of people who are in fair or poor health. And the real thing that nobody was talking about until my group mapped it was segregation. These dark areas are where 90% or more of residents are Black. And, you know, unless you're dealing with those things, trying one off to get somebody a computer isn't going to influence their health. Now, healthcare is already organized as community anchor institutions, but they haven't chosen to take on digital as one of the ways that, as a community anchor institution, they can throw their weight around. I've tried to get them to for years, not very successfully. So I'm looking to all of you to help in this argument. Another big thing that needs to happen is that health systems and public health have to do needs assessments. And unless digital is something they're specifically looking at, it doesn't make it into the plan. This is San Francisco's plan. I did a search. Mobile, broadband, internet connectivity does not come up a single time. Social determinants of health comes up lots of times. So again, we need digital inclusion at the table. Now, there's terrific, now highly local public health data on health outcomes, but they don't have digital access in the data set with it so that you can look at the relationship. So another thing to advocate for. Now, healthcare has all sorts of things that they can do as well to get people connected. One is to screen people for their gaps. They're already screening patients now for their social needs coming out of social determinants of health, but you need to add questions about digital connectivity because despite my begging them for 8 years, they did not add, do you have the internet, to the list of crucial questions they're asking on a standard basis. But so many health systems are asking these questions, so hook on to that. Another great thing is, and again, this is one of my clients, North Star, they're active in libraries all over the country and other places where they have digital literacy assessments online and skill training online. Well, let's get that into healthcare. They have an assessment of, are you able to do telehealth? Kind of automated assessment. So healthcare is the perfect place to do that on a large scale. Now, Andrew mentioned digital navigators. It's something I've been advocating since about the mid-20-teens. I think community health workers are ideally situated to help people get connected and trained, although they themselves are victims of digital exclusion, so they themselves will need to be equipped and trained. Now, health systems should also establish partnerships with community-based digital inclusion organizations. Like in Cleveland, we have a one phone number you can call to get connected to a digital navigator. Another one of my clients, Digitunity, helps set up device ecosystems with organizations. And so that's a great community way to work at the ecosystem level. Another is thinking about how to do this at scale, and healthcare can do this at scale. And many of them now have technology platforms for tracking the referrals that they're making to community organizations for food assistance, shelter, et cetera. We worked with the platform in Ohio to add digital inclusion organizations to it. And so our health systems are screening people. Do you have a computer? Do you have the internet? And if not, they've got right there the list of places they can send them, and they track who gets referred and what the status is. That same organization that made that toolkit for developing tech also made a toolkit for inclusive deployment of digital health in healthcare. And so I really recommend that to you. Now, the final way that healthcare can be involved is they also have big data on health outcomes because of the electronic health records, but they're not thinking about looking at that in conjunction with what technology people have. But those public health, folks have the data, but they need to also link the digital access to the health outcome data. So I know I've thrown a ton at you, and I will just flash these up and have them in slides that I distribute. These are places I've written or other people have written, the health literacy blog at the HIMA. I've written a bunch of blogs for the Telehealth Equity Coalition and Digitunity. My own website, I have a new page on digital health navigators and my own blog that covers covers digital inclusion for healthcare things sort of a lot. Finally, the Arizona State University is launching a digital inclusion leadership certificate, and I'm talking with them about, kind of moderating cohorts of people to go through it together. So the San Francisco Tech Council, could be the perfect cohort to go through a digital inclusion leadership certificate program together. So again, one of my someone I've done consulting with, but I think it's worth your while to know about. So I'll stop there and happy to take any questions.
Well, thanks so much, Amy. There's a lot of great content in there. And Jamie's with a managed care organization in Washington State, and she's going to tell us about their Link to Care Washington program.
So my name is Jamie Robbins. I work for a managed care organization called the Community Health Plan of Washington. I'm here to talk a little bit about a digital navigation program that we've started for community health centers. But just to ground, again, in who we are, and I'm going to throw a lot of acronyms at you because healthcare loves a good acronym. You're going to hear me during this short presentation say the network and the plan. And so when I'm saying that, what I'm talking about is I actually work for two organizations in one, both not-for-profits in Washington State. And they're distinct enough and our funding enough is different that I just wanted to share. So the Community Health Network of Washington, which is really the foundation of this program, and I'll be talking about in detail, represents 21 federally qualified health centers in Washington. As we know, community health centers, or FQHCs, do amazing primary care work, mental health work, behavioral health care. That really is the safety net for a lot of people who don't have insurance or who are Medicaid recipients. So the CHCs are really the delivery system, and this network is the delivery system for a couple managed care organizations, and we are one of them as the health plan. And I mentioned both for clarity of funding and also the differences in the mission, where one is an insurance company to the bone, and then one is a little more community minded, which is where this program comes in, but they interact together, and I think it's worth mentioning both, because our goal is really to promote equitable access. And as the other two speakers have shared already in amazing detail, more beautiful than I could say, tech equity is a public health emergency and it's a social justice emergency. So we wanted to step in, especially after seeing our patients have difficulty accessing care during the pandemic, and try to make a difference. So in terms of the digital divide, I just like, again, to ground in some definitions that we've already covered, but worth saying again. The digital divide is, again, who has and who has not. It's just another iteration of social inequity. Nationally, I have some statistics here from the Telehealth Equity Council that 1/3 of rural areas lack access to high-speed broadband internet across the country, and less than half of patients actually utilize telehealth, which you can imagine for our patients during the pandemic was a big deal when clinics shut overnight. In Washington State, up north where I'm at, I have some info from the US Census, which is that 12% of households don't have access to a smartphone, 6% don't have internet, and 3% don't have a computer. These numbers seem kind of small compared to nationally, but if I look on a statewide county level, which you can see in this map here, which I pulled from the State of the Digital Divide, published last year by Purdue University, you can see that digital inequity is in fact not equitably spread across the state of Washington. I'd encourage everyone, and I can put this link in the chat, to check out your state. It is wild to see the differences. I do also want to note, in terms of data integrity and considerations, that we know when we map on different levels, we'll see different pictures. So if we were to zoom in, for example, to King County, where I am in Seattle, which according to this map is not that big of a deal compared to some rural areas or places with less infrastructure, I can tell you certainly that there are folks here in desperate need. So just wanted to plug that on. The lens we choose tells a certain story. And I also do want to note that our tribal members and tribal lands in Washington State and across the country can choose to opt in or out of US Census participation. And so there also might be people missing from this map. Really, when we look across the state, again, I'd encourage you to check out your own state, but the study found that across the country, people who were in these darker blue, medium blue counties where their index determined that the digital divide was most impactful negatively to the community. Those are often people who are older, have less economic resources, less formal education, and just need extra support. I made this very cheesy hierarchy of needs based shamelessly off of Maslow's hierarchy of needs, which if you want to read more about that is actually based off of a Blackfoot tribal model. That's a story for another day. But 3 iterations later, we have this model here, which we like to talk about when we talk to health clinics and talk to providers to really show the need. So when we think about what it takes for people to engage in technology, and especially in a healthcare lens, to engage kind of at the peak, so a telehealth visit, being autonomous in their care, using a portal, seeing health outcomes improve. Really at the base level, what you need is infrastructure, right? You need internet cables in your area that are kept up to date and functioning. There's a lot of mountains in Washington, so we have a lot of problems getting good cables around. You also need satellite internet access. You need cell towers. If those do not exist, you cannot even begin to talk about using technology to impact your healthcare, to impact your employment opportunities, your housing, and your overall well-being. After you have that base level, so things are in the ground, things are in the sky, you can have devices. So people need devices in their hands that are theirs to keep, that they can learn how to use. That could be a computer, it could be a tablet, it could be a phone. Our program in particular, which I'll talk about, focused on phones, but it really is something in their hand, and they also need internet access in their home that works and that is affordable, to Amy's point about redlining. After you have wires in the ground, you have a device in your hand, you need to learn how to use it. So you need an ongoing relationship with someone who can teach you how to build skills. Learning a new skill in general is terrifying, but learning a tech skill can be even more so and can involve a lot of learning. And we find that once people, and I'm sure this resonates with the group, once you start to learn about technology, not to be hyperbolic, but the world opens up to you and you want to learn more. So you need partnerships and relationships to keep that learning going. And then finally, at the top of my cheesy table here is digital empowerment. So it's people being able to engage with technology in the way that they want to the full extent that they want to impact positively their healthcare, their health outcomes, their employment and social need opportunities, and housing. It really is full spectrum. As I sit, again, wearing 2 hats as this plan and representing the Community Health Network up here and the CHCs doing great primary care work, I cannot put cables in the ground. I still am struggling to understand how a computer works sometimes. So really what we think about in the healthcare space, what we can really easily attain success or promote digital equity through, it's these top 3. So it's doing our best to promote programs across our state, our own program, and also federal programs that get people devices. We can teach them how to use them, and we can help them engage with our clinics, again, in the way that they want to increase their health outcomes and increase their sense of self-autonomy. So in particular, we've used this model to create a program called Link to Care Washington. So this program started just about a year ago. So very, very new. Digital equity is becoming a big priority in Washington state. So we received a Digital Navigator grant to implement in primary care across these federally qualified health centers, digital navigation. So there's 3 big components. We have a free hotline that's staffed by our plan customer service department. So these are people who have lovely, amazing customer service skills. They're bilingual in English and Spanish. We provide free interpreter services because having help in your language is essential to understanding and to receiving the assistance that you need. A big part of the hotline is helping people determine if they're eligible for 2 federal programs that can help them receive free or reduced cost internet and cell service, which is the Affordable Connectivity Program and Lifeline. Spoiler alert, every single Medicaid patient in this country is eligible for those programs, but we need to step up and help promote it and help people navigate it because it is messy, even on a good day. There's no click a button and get your internet. It can take weeks, it can take months. And if someone is in need of support and is already struggling to be tech literate, we need to step in and assist, which is what our hotline provides, as well as ongoing digital literacy education and support. So once they have the device, they have that person over the phone they can call where they have that relationship and get help. The second component is a website. I'll put the link in the chat, but it's nice and simple, linktocarewa.org. I like to think of it as the self-service version of the hotline. So it's people who have enough technology access and digital literacy where they can go online and do some learning themselves. And we have some other modules about digital literacy skills they can help build. And there's information connecting them to the federal programs in our hotline as well. The third component, which I feel like everyone on this call will be most interested in, are in-person sites. We've partnered with the 3 stars on the map here. So our first was Yakima Neighborhood Health Services in Yakima County, Health Point in King County, where I am near Seattle, and Family Health Centers in Okanagan County. I don't know if we have anyone else from Washington on the line, but just to paint a picture, Yakima and Okanagan are extremely rural. Yakima has a lot of migrant farm workers in the community, a lot of their patients with a lot of particular needs. Health Point over in King County, Seattle just in general accepts a lot of refugees and supports refugee immigration to Seattle. So they have a lot of refugee families that they support. And Family Health Centers, very charmingly, is described as a frontier on the census. So you can imagine the infrastructure needs that they have. But between these 3, we have spent more than half of our grant money simply purchasing prepaid devices with 12 months of service, unlimited data, unlimited call, unlimited text to the US, Mexico, and Canada. And these are distributed by community health workers. Looking at you, Amy. I was very excited when you said they're perfect for this, because they are. So this is just another tool in their tool belt where they're addressing SDOH needs, they're addressing health needs, but now they can pull out a phone and say, this phone is for you to keep forever. So you can stay in contact with your clinics, you can access housing, so you can access employment, and I'll teach you how to use it. And if you need more help, here's my good friend at the hotline if I'm not available in person. So that's really kind of the synergy here of these 3 components. No matter how someone enters the program, we're trying to reinforce where their learning is, what their future needs are at any step of the way. I do want to call out again that receiving support in your language is essential and must happen for a digital navigation or inclusion program. So how we've supported that is for the hotline, again, we have bilingual representatives who speak English and Spanish, and we're always looking to hire more languages. We also have free interpreter services for all other languages. And in terms of promotional materials, we've been doing very, very heavy flyering at clinics. And our approach has been whatever language is needed to support a patient, even if it's just one patient, we must translate into that language. So we're up to 19 languages now and counting, and we're hoping to see that grow. Finally, in terms of success stories, as of yesterday, I just checked, we have officially served over 10,000 patients in Washington state, which is really exciting. And what that looks like and includes is we've given out over 1,500 free smartphones, again, prepaid, unlimited for a year. It's theirs to keep, it's theirs to learn. They receive support learning how to use it over the hotline and as well in person. We've received nearly 700 calls to the hotline for assistance, and we've connected over 500 patients to the federal programs of ACP and Lifeline. You see a long list on the right. Don't worry, I won't read them all, but this is just a very high summary of what types of patients we've helped. Some that I'll call out quickly again are migrant farm workers, refugees, older folks, people with single parent families, people with complex medical social needs, people who just want to learn, people who want to take control of their healthcare, people with limited mobility, people without reliable transportation. And I also want to echo that I can tell you stories that will make you weep, but I don't want to cry on camera. I've done enough when I tell stories. It's sensational and it's mind-boggling of how a phone can change someone's life, not just their healthcare, but their entire lives. And so I just wanted to throw that out there, that it's really amazing the work that we've seen the community health workers do. If anyone is interested in creating their own digital navigation program, you work in primary care, you work in another clinic setting, I just wanted to share some best practices and lessons learned just again from the first year of the program. What we found is it's really important to meet people where they're at. You got to meet them physically, so in person. You also need to provide support over the phone or over the computer if that's their preference. And you also have to meet them emotionally and mentally, right? Because building relationships is essential to digital equity promotion and improving health outcomes. We think of the ACP and Lifeline as a starting point. There's a lot of people that are missed. For example, if you make 201% of the federal poverty line, you're out. If you don't have a social security number, sometimes you're out. If you don't have a permanent address to receive communication about the subsidy after you apply, you're out. So we've tried to fill the gaps, and I would challenge people to think of the people in their community that might get left behind and start there. Again, it's important to offer services in the language of the patient's choice. If you're working across many different clinics or health systems, you have to find a champion who's going to lead the charge internally. And then ideally, you can find clinics who are already doing the work. I guarantee everyone on this phone call, if you work in healthcare, you and your team or your company has done bits and pieces of digital navigation, but maybe not the full picture. And maybe there's not a staff member whose job it is to do that, or it's not officially integrated. And there is huge value in naming it and integrating it into a role. If you do have multiple components, again, to try to meet patients where they're at, make sure that you're coordinating the support so it's really seamless for the patient. Make sure you're getting the word out to everybody and their mom about these programs because they're really essential, and you would be surprised and delighted to see who might benefit in maybe different communities that you wouldn't expect. The more sobering recommendations is everything's going to take longer than you expect. I feel like we all know this on just a human level, but it's worth saying again as you try to plan an ambitious program, and it's worth taking the time to build it right with equity at the focus. And also just knowing that, again, we're still in a pandemic. There's some interesting banking things going on. Sometimes there's shortages. There might be things outside your control that impact your ability to implement the program in the way that you want, but don't be discouraged and reach out for help because we've been through a lot good and challenging in the last year. And there's a lot of good experts on the phone as your resources. That's all I have. Thank you so much. I'm going to figure out where my stop sharing screen went.
There you go.
I think I found it. Okay, thank you. Thank you so much.
Great, Jamie. Thanks so much. But such an inspiring kind of, story just in terms of what you've been able to do. I'm just curious, where did you get your kind of direction from in terms of putting this program together in ways that, my understanding would be there's not a lot going on within health systems like this. So, you're very kind of early in the game in that sense. So kind of, where did you get your instruction from, I suppose is my question.
That's a good question. A mix of our contractual grant requirements, which honestly shaped a good portion, but were very helpful because I think they had digital equity at the lens. So, we had to target, for example, Medicaid patients, which easy enough, that was our target anyway. We had to make sure that we were not offering the service only to our Medicaid enrollees, but to everyone. So if someone doesn't have insurance, they're enrolled in another Medicaid plan, they can still receive the service. So that shaped, I think, kind of the guardrails. But in terms of design, we leaned heavily on the National Digital Inclusion Alliance Digital Navigator model. I will say, if I could rewind it back a year, I would call Amy as we were building the program, but I'm very, very overjoyed to see that some of her key findings are aligned with how we did build it. But it has been a lot of iteration. It's been a lot of keeping outside of those guardrails again, and some of the framework and support, keeping our minds and hearts open to what do the community health centers want and how can we address the need, because every clinic that we've worked with has a slightly different need for their patient population. So that would, I think, be the biggest wisdom I could share is making sure that you're not applying a solution kind of routinely in a way that it wouldn't actually be fit for the patients that you're trying to serve, and really lean on those frontline workers at the clinics, lean on the providers who work day to day with those patients, and hear from them what are their unique needs and how can I make this program fit their unique needs.
Honored to have a local startup here, which is called We the Trillions. And Lamiaa is the CEO and founder of this startup. And it really is a kind of interesting kind of organization, incorporating the latest peer-reviewed research, emerging science in terms of the human microbiome, as well as kind of trends in the design of nutrition and food kind of products, and really kind of help focusing on medically tailored meals in particular, you know, for Medicaid population. And there's a lot of developments that have been going on, both in terms of funding and policy and, you know, other aspects that really make this an area I think that's going to be exciting in terms of what it can deliver in linking food with health outcomes. So Lamiaa, I'll hand over to you.
Thank you so much, Andrew and Carla, for having me. I'm not going to do slides because I have a larger story to tell and kind of explaining the bridge between technology and food and like why is this relevant to you all. And also thank you for all the presentations. This is all like it rings the bells that we hear every day, and I'm happy to tell you more about our story. So as Andrew said, I'm the founder of We the Trillions, and we're a public benefit corporation, and our mission is really to create a platform for preventative healthcare that could be affordable and accessible, and also kind of having a 360 degree on what's going on from a patient perspective. So for background, my background is in engineering, but I started my career in drug discovery at Sanofi in the pharmaceutical industry. And one of the main projects I've been working on was the launch of the first blood glucose monitoring with Apple. And it was at that time, it was really like a big innovation. And as we said, like it was all about how we can get more blood glucose monitors in people's hands. And there was like all this excitement about tracking and monitoring, which made me think about, okay, like there's this huge science and technology leap that's happening in how can we track more, how can we monitor more, as you can see whether, so I was saying there's this whole trend about how can we track and monitor and know how many, like what are we eating, what is it doing to our body, and so on. And I consider this to be the infrastructure, the pipe, as Jamie was saying just right now. It's this whole idea of knowing what's going on, but what is the innovation from a technology perspective that's happening in the actual food that we're getting. From an innovation perspective, we've been seeing all the Uber Eats of the world and how can we get pizza faster kind of type of innovations, which basically solve the issue of logistics, which is a big one for accessibility, especially as these innovations are now enabling and working in partnership with so many health security just programs across the country, and really making sure that the food security needs are addressed, especially with the food deserts and so on. But now the second chapter that we're working on, and that's really like where we're grounding our whole mission on With the Trillions, is how can we apply the same efficacy that's going on in the drug world into food, so that food as medicine is not the same one size fits all salad that everyone needs to be eating, but actually something that is a prescription grade that your specialty care or primary care or RD or any healthcare provider you're working with is actually optimizing. And there are many angles to this. I mean, the first one, the straightforward, is really the fact that 80% of the costliest diseases in the US are preventable through food and other social determinants of health, but food is really number one. And the second thing is that the 2/3 of people with chronic conditions are actually dealing with two to three conditions at the same time, which makes the idea and the answer of what is it that we need to be eating so it gets very complicated very fast, and especially in setups where people are relying on very limited resources or community services and so on. So the three things that we've done is, one, saying, okay, the first problem is we don't know what is it that's the best diet program that needs to be given to someone dealing with thyroid and menopause and type 2 diabetes at the same time, because these people go to three different specialty care doctors who give them different advice. And if they're lucky, they would be referred to a registered dietitian who also needs to be in like one consultation, depending on insurance and so on, to give them the right answer. And then they need to go to the grocery store and find the right food and find the time, given the 2 or 3 jobs they're on, or even if they're unable to do so, to be able to cook it in the right portions over a very long period of time. So I'm exhausted just talking about it. So can you imagine actually doing it? And what we're doing is actually, how can we make this possible. So there's like this whole gap that needs to be solved by just using technology and machine learning to extract the right information and match it with patient data. So that's kind of step one. What we do is that all these findings from matching patient data with the existing science, and also kind of vetting it for contradiction and for who's funding the research and how big is the sample and is it really solid research. From that, actually making the food, sending it to people's homes and tracking the symptoms, which makes a whole difference between telling you what to do and actually taking away all that, which builds a model. And that's kind of the goal here, is to really get the payers to pay for it the same way they would pay for your medicine. And last September, the White House has signed an executive order into ending diet-related diseases. And by 2030, every state in the U.S. needs to have some kind of program so that eligible population with a diagnosis can have the reimbursement for medically tailored meals. Now with Pooja here, who's my colleague, like we spend our days trying to talk to people about medically tailored meals. It's as if we're speaking some other planet's language, even though it's like self-explanatory, but there is still like this divide about, oh, are you just doing organic, or is this like a food security program? But the question really is, how can we customize and optimize the dollars that are going to food security and matching them with public health and solving two problems at once? And that's why, like, what the work that we're doing is really, and anyone feel free to reach out. We're trying to work with counties across California at first to be able to get this for the 4 million eligible patients under Medi-Cal, who can have up to 6 months of free food should they have just a diagnosis. And that's something that could completely change the map of chronic conditions in California. And based on that, we're open to work with all health plans and all the insurance companies across the US